Welcome to the funnel effect. If you've ever scratched your head wondering why two major clinical trials looking at essentially the same heart condition could end up pointing in seemingly opposite directions, well, you are definitely in the right place today. We're doing a deep dive into some really crucial state-of-the-art research in cardiovascular medicine. We're focusing on a particularly challenging group of patients, those with ischemic left ventricular dysfunction, or ILDD. Our guide for this journey is a truly comprehensive and, I think, forward-looking review paper. It pulls together a massive amount of evidence to try and build a new framework for how we treat these patients. It's titled Revascularization in Ischemic Left Ventricular Dysfunction, a pathophysiology-guided evidence-based approach. And the author list, well, it's a remarkable group of experts. Matthew Ryan, PhD, Alexander G. Truesdale, MD, Gavin J. Murphy, MD, Syed Adam Izad, PhD, Stephen Freems, MD, Alexander J. Lansky, MD, Elmir Omerovich, PhD, Stefan Windecker, MD, Eric Velasquez, MD, Mark C. Petrie, MECHB, Ajay Kirtine, MD, Greg W. Stone, MD, and Devaka Pereira, MD, published in JCC, Cardiovascular Interventions.
Yeah, seeing that kind of lineup all collaborating on one review, it tells you straight away just how much uncertainty and complexity still surrounds this whole clinical area. This paper isn't just, summarizing old research. It's really trying to shape the future of care here. And the core problem they're tackling is, frankly, staggering. ILVD. It's the single most common cause of heart failure with reduced ejection fraction, what we call HFrEF, and it carries a really disproportionately high risk of mortality. It's a serious condition.
Right. And historically, the path forward seemed almost, well, automatic, didn't it? If a patient showed up with poor heart function, weak pump, and blocked arteries, the default move was almost always revascularization.
Absolutely.
Either major open heart surgery, coronary artery bypass grafting, CABG, or a less invasive procedure with catheters, percutaneous coronary intervention, PCI. The thinking was pretty straightforward. Fix the plumbing, improve the blood flow, and the pump itself should get better, leading to longer survival. Simple, right?
Simple, logical, but that underlying assumption has been seriously challenged lately. Over the last couple of decades, the evidence base has gotten, well, messy, really complicated by two huge randomized trials that seem to give contradictory answers. So what used to be almost clinical dogma, intervene automatically, is now a highly nuanced, multidisciplinary decision. It has to be case by case, and it relies entirely on following an evidence-based framework.
Okay, so that's our mission today then. To really extract that framework from this review, we need to go beyond just reporting the findings. We've got to understand the complex pathology underneath it all, try to make sense of the conflicting survival data from those key trials, Sittich and Revive see this too.
Yeah, those are the big ones.
And then really drill down into the incredibly detailed, meticulous, systems-level planning and execution that's absolutely required to do high-risk PCI safely in these, well, uniquely fragile patients.
Exactly. There's a lot to unpack here.
Let's get into it.
Okay, so first things first, let's just establish the scale of this problem. Coronary artery disease, CAD. It's not just some minor factor in heart failure, it's the main driver. It accounts for somewhere between 40 and 60% of all patients diagnosed with heart failure. That's huge. And if your heart failure is caused by ischemia, by CAD, you automatically face a worse prognosis compared to someone whose heart failure comes from, say, a non-ischemic cause, like a genetic issue or a toxin.
Those prevalence numbers are just enormous. But the review points out this major gap, almost a disconnect, in the initial diagnosis phase. It says even though maybe half of all heart failure patients have CAD as the likely cause, only about 10 to 20% actually get the specific tests, like a coronary angiogram, to confirm that's the root cause. That seems like a really surprising miss rate.
It is a surprising miss rate, and it's a critical gap because it directly impacts patient outcomes. Getting that timely, accurate diagnosis of the underlying CAD, it's just non-negotiable. Why? Because knowing the cause helps refine the prognosis, obviously, but it fundamentally dictates the entire management plan. Knowing it's ischemic allows the team to properly think about revascularization, maybe implantable devices, or just really intensifying that guideline-directed medical therapy, the GDMT. If you miss the diagnosis, that patient might be managed suboptimally, maybe for years.
And then when these patients do eventually get referred for a procedure like PCI, they're already starting from behind, risk-wise. The data the authors pulled together here on pre-procedure assessment, or lack thereof, is pretty eye-opening. I mean, less than half of all PCI patients just generally get a formal LV function check beforehand.
Yeah, that figure is quite striking. It arguably reflects a gap in, let's say, necessary diligence, especially given the procedural risks we're talking about. And when you do look at the patients who are assessed, their vulnerability just jumps out. 3 out of 10 undergoing PCI have at least mild LV dysfunction, and 1 in 10, which is a huge proportion, have severely reduced ejection fraction, LVEF. Their risk profile is just orders of magnitude higher than someone with normal heart function going for the same procedure.
And that risk isn't just theoretical, right? The source data shows the chance of dying shortly after PCI is 2 to 5 times higher for patients with severe ILVD compared to those with good heart function. The margin for error during these procedures seems incredibly thin.
It is razor thin. And that fragility, it comes directly from the underlying heart muscle problem, the pathophysiology. See, ILVD isn't just one single thing. It's really a spectrum. It's characterized by 3 different processes, often happening at the same time, maybe even side by side in different parts of the same heart. Understanding this trio stunning hibernation and infarction is really fundamental to appreciating why treatment decisions are so nuanced.
Okay, let's break down that spectrum,
Mm.
starting with the most temporary stage.
Yeah.
Stunning, what's going on there mechanistically.
Stunning. Think of it like a muscle that's been overworked and is just temporarily shocked. It's defined as a transient uncoupling of blood flow perfusion and the muscle's contraction. This happens after an episode of ischemia. So the muscle might be getting enough blood flow now, but its function is down because of the stress from that previous lack of oxygen. The key thing is if the ischemia doesn't happen again, the muscle function usually recovers completely, often within hours or maybe days.
Okay, temporary setback. Then we move to hibernation. That sounds like a longer-term issue.
Exactly. Hibernation is more persistent. It's a chronic state of that perfusion contraction uncoupling. The muscle is basically just ticking over at a very low level. It's chronically downregulated its function, even if blood flow is normal or maybe still a bit low. The theory is that it's adaptive, maybe an energy-saving move. The heart sacrifices function to conserve energy, ATP, and hopefully promote cell survival. This hibernating muscle stays dysfunctional until you fix the underlying problem, until you remove that ischemic substrate, the blockage, usually with revascularization. Recovery is possible, but it depends on successfully getting that blood flow back.
And the final stage, the one everyone knows, is infarction.
Infarction is the endpoint, really. It's ischemia-driven cell death, myocyte necrosis. It's permanent. It tends to progress in a predictable way, starting from the inside layer of the heart, the endocardium, and moving outwards towards the epicardium. This is the irreversible damage. It's what drives that negative remodeling, the heart changing shape for the worse. And critically, this scarred, dead tissue, it's a major source of arrhythmogenesis.
Arrhythmogenesis, meaning dangerous heart rhythms.
Exactly. Those chaotic, potentially fatal ventricular rhythms that can lead to sudden cardiac death. The scar tissue is often the culprit.
So if these 3 states, stunning, hibernation, infarction, can all exist in the same heart, how do doctors avoid that core diagnostic problem the review talks about? Distinguishing real ILVD from what they call bystander CAD. Is the coronary disease the cause of the weak heart, or is it just there alongside some other heart muscle problem?
That is probably the single trickiest issue because, as the review points out very clearly, there's currently no internationally agreed upon definition for ILVD. There's no simple checklist. You have a patient low ejection fraction, blocked arteries, and you have to make a judgment call. Is the CAD the reason for the heart failure, or does the patient maybe have primary cardiomyopathy, some other muscle disease, and the CAD is just sort of incidental, a bystander finding?
If there's no consensus definition, how do experts actually make the diagnosis then? It sounds like it has to be based on probability.
It absolutely is. It ends up being a probabilistic approach, largely based on just how much coronary disease there is. The paper suggests, and this makes sense, that the greater the extent and the severity of the CAD, the higher the probability that it's actually an ischemic cause. They mention a really useful practical tool here, the BCIS myocardial jeopardy score.
Right. Let's quickly explain that score for people listening.
Sure. The BCIS score, it's basically an anatomical calculation. It quantifies how much of the heart muscle is potentially at risk based on where the blockages are and how severe they are. If that score is 6 or higher, which usually means you've got significant disease high up in a major artery like the left anterior descending, the LAD, or you've got true multivessel disease, that score has a pretty high specificity for pointing towards an ischemic cause in patients who already have an LVEF below 35%. Basically, a high score strongly suggests, look, there's enough blockage here that this is almost certainly why the heart is weak.
Okay, that helps put some numbers on it, but like you said, it's still not a perfect yes-no answer.
Not at all, which is why we really need to think of ILVD as a spectrum. One end is purely ischemic dysfunction, the other end purely myopathic, some other muscle disease. And in that big area in the middle, the gray zone, you need a really nuanced approach. This is where the multidisciplinary heart team becomes so incredibly important. They have to weigh up, okay, should our therapy primarily target the CAD? Or should it primarily target the heart failure process itself? Because just treating the CAD might not help much if the underlying problem is actually something else entirely.
Okay, so the treatment landscape for ILVD, as you mentioned, is really defined by these two huge randomized trials. CZ Garnet, which looked at surgery, CABG,
Right.
and Revive BCIs2, which looked at the catheter-based approach, PCI. Let's start with CZJH. That one tested CABG against just medical therapy in stable patients.
Yeah, ST-CIEH was a massive undertaking. A prospective trial enrolled over 1,200 patients across the globe. The main criteria were having coronary disease that was suitable for bypass surgery and an LVEF less than 35%. And crucially, they were looking at chronic heart failure. They specifically excluded patients who had unstable angina or a very recent heart attack that was clearly driving the immediate problem. They wanted to know about the long-term survival benefit for stable, chronic ILVD.
And right off the bat, the surgery itself carried a significant risk.
It absolutely did. The initial results showed that upfront cost of major surgery, there was an early hazard. About 9% of the CIBG patients either died or were still hospitalized 30 days after the operation. That short-term risk, that mortality spike, was a pretty significant factor and partly why the results further out were initially, well, underwhelming.
Because after nearly 5 years of follow-up, STJH was essentially neutral, wasn't it? The death rates were very similar.
That's right. At 4.7 years, mortality was 36% in the CABG group versus 41% in the medical therapy group. Now, there was a trend suggesting surgery might be better, but it didn't hit statistical significance at that point. And honestly, a lot of doctors looked at that midterm data and thought, okay, maybe surgery is just too risky for this group and doesn't give a proven survival advantage.
But this is where the story gets really interesting, because the investigators kept following these patients. And that long-term follow-up, the stitches extension, that provided the real game-changing result for surgery, didn't it?
This is absolutely the critical finding for CABG in this population. When they extended the follow-up out to nearly 10 years, 9.8 years on average, a significant and importantly an enduring survival benefit finally emerged. The number of patients who died was clearly lower in the group that got CABG, 59% versus 66% in the medical therapy-only group. That 7 percentage point absolute difference was highly statistically significant.
That's a really compelling difference over the long haul. Did they translate that into actual years of life gained?
They did. The authors calculate that, on average, CIBG added about 18 months of life expectancy over that extended follow-up period. So it really validates the strategy, right? Using an invasive procedure that has some short-term risks, but achieving a powerful long-term prognostic benefit. And it wasn't just survival. The quality of life improvements seen with CIBG were also sustained and significantly better compared to medical therapy alone over that long period.
But it wasn't a universal benefit across the entire group, was it? The review mentions an important subgroup finding.
Yes, that's a key nuance. When they looked closer, that survival benefit was primarily restricted to the youngest patients in the trial specifically, those who were younger than the median age of 60 when they were randomized. And this really highlights a critical point. When you're looking at survival benefits in complex, often frail populations like this, non-cardiac causes of death start to become much more prominent as patients get older. So the CIBG benefit, which is mainly driven by reducing cardiac death, it kind of gets diluted in the older, more complex patients who have lots of other health issues.
Okay, so CKG offers a real but delayed survival advantage, especially for younger, perhaps more robust patients. Now let's switch gears to the PCI side with Revive BCIS2. This trial wanted to see if the less invasive approach could deliver similar outcomes.
Right. Revived BCIS2 was a really well-done, randomized trial based in the UK. They enrolled about 700 patients. The criteria were similar in terms of LVEF, less than 35%, but they had a key procedural requirement. The coronary disease had to be extensive, defined by that high BCIS jeopardy score of 6 or more. And importantly, they mandated evidence of myocardial viability. They wanted to ensure there was potentially recoverable heart muscle. Then they randomized patients to either PCI plus the best medical therapy or just the best medical therapy alone.
And what did they find after, what was it, about 3.5 years of follow-up?
They found a distinctly neutral result. The primary outcome, a composite of dying from any cause or being hospitalized for heart failure, was virtually identical in both groups. 37% in the PCI group versus 38% in the medical therapy group. This finding was a major surprise to the cardiology community. It really challenged that long-standing belief that simply fixing the ischemia, opening the blockage, must lead to better long-term outcomes.
You mentioned earlier there was maybe an initial hint of benefit regarding quality of life.
Yes, that's true. PCI did provide a statistically significant improvement in quality of life scores, specifically using the Kansas City Cardiomyopathy Questionnaire, the KCCQ. That benefit was seen at 6 months compared to the medical therapy group. But, and this is the crucial part, that difference completely vanished within 2 years of randomization. So the quality of life benefit was real but transient. It was functional, not sustained, and importantly, it didn't translate into any improvement in prognosis, in survival, or heart failure hospitalizations.
Okay, so this leaves us with this apparent contradiction, right? We have a delayed long-term survival benefit for surgery from stitches, but basically no survival benefit, at least in the short to medium term, for PCI from revived BCIS2. How did the authors of this review try to reconcile these two powerful but different sets of results?
They did something really smart. They conducted a pooled individual patient data analysis, comparing the participants across both trials. And this comparison revealed the key insight, the likely reason for the discrepancy. They found that the overall event rates, the actual rates of death and heart failure hospitalization, were significantly lower in the patients enrolled in revived BCS2 compared to those in Stooch. And that was true regardless of which treatment arm they were in, whether they got intervention or just medical therapy.
Wow. Okay, so the patients in the later trial just did better overall. That fundamentally changes how we look at managing ILVD, doesn't it?
It absolutely does. And it speaks directly to the incredible evolution, the revolution, really, in guideline-directed medical therapy, or GDMT, that happened in the years between these trials. Remember, SCACH enrolled patients way back between 2002 and 2007. Back then, optimal medical therapy was mostly ACE inhibitors and beta blockers. Revived BCS2 enrolled much later, from 2013 to 2020. That decade-plus gap saw the widespread adoption of newer, incredibly effective drug classes, things like the angiotensin receptor neprilysin inhibitors, ARNES, and more recently, the SGLT2 inhibitors.
So the background medical therapy available during the revived era was just far more powerful at actually modifying the disease course than what was available during SE.
Exactly. The medical therapy had become so good, so effective at reducing heart failure hospitalizations and mortality on its own, that it likely created an extremely high bar for any intervention to clear. You could argue the GDMT in the modern era was so effective that the additional incremental benefit you might get from PCI was essentially neutralized, or at least rendered statistically undetectable within the relatively shorter follow-up period of revived BCS2.
Which then leads directly to those critical unanswered questions the review raises. First, if the SDA-CH patients back in the early 2000s had access to today's aggressive four-pillar GDMT, would that survival benefit from CABG still look so dramatic?
That's question number one.
And question number two, could a survival benefit for PCI actually emerge, maybe similar to that delayed benefit we saw with CABG, but only if we follow the revived BCIS2 patients for much longer, say 8 or 10 years?
That's precisely the crux of where the research needs to go next. These trials didn't necessarily prove revascularization is useless. What they proved is that modern GDMT is truly transformative. The relative value proposition of fixing the plumbing versus optimizing the pharmacology is still being worked out. And the answer is almost certainly going to be highly dependent on the individual patient.
Okay, this next part feels like a really big shift. For decades, the rule in managing ILVD seemed crystal clear. Before you intervene, you had to prove viability. You needed to show the heart muscle wasn't dead, that it was just hibernating or stunned and could potentially recover. But the contemporary evidence laid out in this review seems to completely overturn that dogma, at least for making decisions about prognosis. That feels like a massive change in thinking.
It really is a major paradigm shift. The historical thinking made perfect sense, right? Why would you put a patient through a major, risky procedure to restore blood flow to tissue that's already dead, already infarcted? The assumption was that only viable myocardium, the living but sleeping muscle, could recover function after you fix the blockage. And that recovery was thought to be what improved the patient's long-term outlook. So viability testing using scans like PE or SPECT or stress echocardiography became pretty routine for selecting which patients should get revascularized.
But when this assumption was actually put to the test in trials, it didn't hold up, did it? The idea that viability testing could pick the winners just didn't pan out. Let's walk through the evidence, maybe starting with PR2.
Yeah, PR2 was an important early Canadian trial. They randomized patients to either have their management guided by PET viability results or just receive standard care without that specific guidance. And at 1 year, there was absolutely no difference in the main outcomes: cardiac death, heart attack, or hospitalization. Using viability testing to guide management simply didn't provide any advantage. It didn't improve outcomes.
Okay, so that was an early hint. What about the STCH viability substudy? That was embedded within the big CABG trial.
Right. The STS viability study looked specifically at about 600 patients within STH who had viability testing done. And again, the results were pretty definitive. The patient's viability status, whether they had large amounts of recoverable muscle or not, completely failed to predict their likelihood of dying from any cause. It didn't matter if you had viability or not. That information didn't help select who would actually benefit from getting the bypass surgery. That finding was really damaging to the whole viability hypothesis for prognosis.
And probably the most compelling nail in the coffin for viability as a prognostic gatekeeper comes from revised PCIS2, the PCI trial, because they actually required patients to have viability to even get into the trial, didn't they?
Exactly. Viability was an entry requirement, yet the overall trial result was neutral for PCI versus medical therapy. But even more telling, they specifically analyzed whether the amount of viability interacted with the risk of bad outcomes with PCI, and they found no interaction whatsoever. Instead, that analysis delivered what I think is the critical insight. Adverse prognosis, the risk of bad things happening, was strongly associated with the extent of irreversible scar, the amount of dead infarcted tissue. It was not associated with the amount of recoverable viable myocardium.
Wow. So let me make sure I understand that. Viability testing tells you what might get better functionally, but it's the amount of scar tissue that actually predicts whether the patient is likely to die.
That's the essential mechanistic understanding we have now. The presence of scar tissue drives poor prognosis primarily because that scar is the substrate, the source, for those life-threatening ventricular arrhythmias we talked about. And it also drives ongoing negative remodeling of the heart. That risk persists, driven by the dead tissue, regardless of whether you've successfully restored blood flow to the adjacent, viable, but maybe hibernating tissue. The danger comes from the scar.
Okay, so viability testing is out for selecting patients based on prognosis. What about ischemia testing? Does measuring how much reversible ischemia someone has predict whether revascularization will help them live longer?
The story there is pretty similar, unfortunately. While the really big ischemia trials, like Ischemia and Courage, generally excluded patients with a severe level of LV dysfunction. Both Stitch and revived BCIs2 did allow for ischemia testing at the discretion of the treating physicians. And when they looked at that data, they found a consistent pattern in both trials. There was no association found between the amount of measurable ischemia and either the likelihood of survival or the effectiveness of getting revascularized, either CIBG or PCI.
So putting it all together, we arrive at this clear, contemporary, evidence-based position. And it really is a fundamental change from how things were done not that long ago.
Yeah, the definitive stance now, based on this evidence, is that viability testing and ischemia testing should not be used to decide whether a patient with stable ILVD should get revascularization specifically for the purpose of improving their prognosis, of helping them live longer. If the patient is stable, maybe asymptomatic or minimally symptomatic on good medical therapy, those functional tests just aren't the right tools to select them for invasive procedures aimed purely at survival benefit.
That being said, the review is careful to point out that advanced imaging does still have a role. It's just shifted. It's moved away from prognostic selection and more towards procedural planning.
Absolutely. That's the crucial distinction. If a patient already has a solid clinical reason to get revascularized, the most obvious examples being angina that's limiting their life despite medications, or maybe they've had an acute coronary syndrome, then imaging becomes incredibly valuable. But its value is in guiding how the intervention is performed, not whether it should be performed for prognosis.
How does that work in practice? Say, in the cath lab planning for a PCI.
You'd use the imaging, maybe cardiac MRI showing scar, or perhaps stress imaging showing ischemia location to decide exactly where to focus your efforts and procedural risk. Imaging can help you target only those blockages that are feeding areas of viable or clearly ischemic muscle. Those are the potential high-yield targets. Conversely, and just as importantly, it helps the team make a conscious decision to defer intervention on arteries that supply areas of extensive, dense scar. If you have a complex, risky blockage that only feeds dead tissue, subjecting the patient to a high-risk procedure offers zero functional benefit and only potential harm. So this selective approach, guided by imaging, helps optimize the potential for functional improvement while minimizing the procedural risk.
Oh.
Deft. Okay, now let's circle back to the concept that really complicated those trial results we discussed, guideline-directed medical therapy, or GDMT. Before we even start thinking about revascularization, whether it's surgery or PCI, GDMT is the absolute foundation, the cornerstone of care for every single patient with ILVD.
It really seems like GDMT isn't just a supportive player anymore. The review cites this incredible estimate of 5 to 8 year gain in life expectancy. That makes GDMT the primary life-extending therapy here.
That number 5 to 8 years is genuinely transformative, and it's something we absolutely have to stress to patients. It underscores the power of modern pharmacology. The review specifically emphasizes the synergy of what we now call the 4 pillars of GDMT. These are essential, regardless of any decisions about pipes and plumbing. Pillar number 1 is blocking the renin-angiotensin-aldosterone system. That means using RAAS inhibitors like AC inhibitors or ARBs, or ideally the newer, more potent angiotensin receptor neprilysin inhibitors, the ARNIs.
Okay, pillar 1, RAAS blockade, preferably with an ARNI. What's pillar 2?
Pillar 2 is beta blockers. These are crucial. Their main job is to reduce the stress on the failing heart, slow the heart rate, and manage that chronic compensatory drive that can be harmful long term.
Got it. Pillar 3.
Pillar 3 involves mineralocorticoid receptor antagonists, MRAs like spironolactone or epinephrine. These help combat the negative remodeling effects, the heart-changing shape driven by chronic neurohormonal activation in heart failure.
And the 4th pillar, the newest blockbuster class.
That's the sodium glucose cut transporter 2 inhibitors, the SGLT2 inhibitors. These drugs, initially developed for diabetes, have shown just profound benefits in reducing heart failure hospitalizations and mortality across the board, even in patients without diabetes. It's one of the biggest advances in heart failure management in the last decade. So getting patients on and meticulously titrating doses of these 4 classes is absolutely paramount. It's job number 1.
Beyond those core 4 pillars, what other medical therapies are generally essential for these patients?
Well, lipid-lowering therapy, usually with statins, is recommended for pretty much all patients with coronary artery disease, regardless of their LVEF. That follows standard chronic coronary syndrome guidelines. And of course, rigorous management of blood pressure and other comorbidities like diabetes is also critical.
Okay, let's shift from meds to devices. Specifically, cardiac implantable electronic devices, CIDs. Like defibrillators, ICDs.
Yeah.
The review mentioned a historical tendency to maybe delay putting in an ICD if revascularization was planned.
Yeah, that was based on the hope, the assumption really, that fixing the blockages, restoring blood flow would somehow reduce the risk of sudden cardiac death by getting rid of ischemia. But the arrhythmia analysis from Revive BCIs2 basically showed that hope was unfounded, at least for PCI. They found the rate of death, or aborted sudden death, remained quite high, around 40% over the follow-up, and critically, it was not affected by whether the patient received PCI or not.
Which really reinforces that mechanistic link we talked about earlier as the scar tissue, not just the active ischemia that's driving the arrhythmia risk.
Exactly. Scar tissue is permanent. It's electrically unstable. In severe ILVD, it plays a much bigger role than transient ischemia in generating those life-threatening ventricular arrhythmias. So just relieving ischemia with PCI doesn't significantly change that underlying arrhythmogenic substrate, the scar itself.
So the evidence is pretty clear then. Don't wait to implant the device if it's indicated.
Correct. The current evidence does not support deferring CIE implantation, like an ICD, in stable ILVD patients just because revascularization might be pending. The patient's high risk of sudden cardiac death from their scar tissue persists, whether or not you fix their coronary blockages. So decisions about device implantation should really proceed independently based on the established guidelines for primary prevention of sudden death.
Now let's look back at the surgical pathway, CABG. Despite that initial upfront risk we discussed, those long-term stitches results still provide a pretty strong reason to consider surgery in specific patients. When do the international guidelines give really strong Class 1 recommendations for CABG?
The major international guidelines, both European ESC and American AACC, give strong Class 1 level of evidence B recommendations for CABG in ILVD patients who meet specific criteria. LVEF less than 5%, significant multivessel coronary disease suitable for bypass, and acceptable surgical risk. This strong recommendation is largely a direct result of that sustained long-term survival advantage that was finally confirmed after 10 years in the STICKIS follow-up.
And the review also mentions that the case for surgery gets even stronger if there's coexisting valve disease.
Yes, absolutely. If a patient also has severe primary mitral regurgitation, a leaky mitral valve that isn't just due to the enlarged ventricle that significantly strengthens the indication for CAG, there was a STSeach sub-study showing that performing a mitral valve repair at the same time as the bypass surgery was associated with even better outcomes, including reduced mortality. Right.
Right.
If you already have the chest open for bypass, fixing the significant valve leak simultaneously provides a powerful synergy and optimizes the result.
Okay, so we have this really complex landscape. Powerful GDMT, independent decisions about devices, a strong mandate for CABG in certain patients, and kind of a neutral stance on PCI for prognosis alone. This all has to be synthesized by the heart team. And this is where those non-technical factors like patient priorities really come into sharp focus.
Shared decision-making is absolutely central here, particularly because many of these patients are older, maybe frail, have lots of other health problems. For these individuals, prioritizing quality of life, minimizing the immediate risk of a big procedure might legitimately outweigh the prospect of an 18-month survival benefit projected way out over 10 years. The patient's values, their goals for care, have to guide the final decision, and that preference needs to be elicited and respected.
The paper's mention of potential adversarial dynamics within the heart team itself was quite candid and insightful.
It's a real-world consequence of having mixed trial data like this. You might have surgeons who are very focused on and committed to the long-term survival data from stitches for ABG. And you might have interventional cardiologists who are perhaps more focused on the immediate procedural risks, especially with PCI, and the neutral short-term outcome data from Revive NECIDES 2. These differing professional perspectives on risk, benefit, and timelines can sometimes create friction. The key task for the multidisciplinary team, the MDT, is effective communication. They have to try and transcend those potential biases and keep the patient's holistic interest, considering their risk tolerance, their quality of life goals as the absolute primary focus.
And what if, after all that discussion, the patient is ultimately deemed too high risk for any revascularization procedure, either CABG or PCI? What's the team's responsibility then?
In that situation, the clinical team has an absolute obligation to ensure meticulous, truly optimized GDMT. This often means involving heart failure specialists to make sure every medication is maximized. Furthermore, the review rightly emphasizes that for patients who are declined for high-risk intervention, or perhaps for those where the long-term prognosis is known to be poor and symptoms are hard to control, palliative care specialists should be brought in early, not just at the very end, but earlier on, to help manage symptoms and ensure maximal comfort and quality of life, especially when aggressive disease modification is no longer feasible or desired.
Okay, we've established that having that low LVEF, below 35%, is the single biggest predictor of bad things happening immediately during or after PCI. The heart just doesn't have much reserve. So when we get into the actual procedural details, this is where the meticulous planning and system-wide rigor become absolutely critical. This section of the review reads almost like a step-by-step guide for minimizing catastrophic risk.
It really does. And the high-risk nature isn't just the weak heart muscle. It's compounded because these patients are often older, they tend to have more widespread diffuse coronary disease. And that means the PCI procedure itself is likely to be more complex, involve treating more lesions, and take longer. Meticulous planning is really the only way to counteract the fundamental problem. These hearts simply cannot tolerate prolonged periods of ischemia or hemodynamic instability.
Let's start with that pre-procedure planning phase. Defining the goals, selecting the right targets for intervention.
Yeah, this starts way before the patient even gets to the cath lab. The heart team needs to sit down, review the coronary anatomy from the angiogram alongside any available myocardial imaging like viability scans or scar maps from an MRI. The purpose isn't prognosis selection anymore, remember? It's purely to estimate the specific risk versus benefit of treating each individual blockage. The goal should be to define, okay, what's the minimum acceptable revascularization we need to achieve to hopefully relieve this patient's symptoms? And maybe what's the ideally achievable level of completeness that might maximize functional recovery if it can be done safely?
And the fact that PCI can be staged, done in multiple steps, that's a key advantage here compared to the all-or-nothing nature of CIB surgery, right?
It's a major advantage, absolutely. That flexibility to stage the procedure is crucial. You can look at the overall burden of disease and decide, okay, does the risk-benefit profile allow us to try and tackle everything in one complex, maybe mechanically supported procedure? Or would it be dramatically safer to use a staged approach? Maybe treat the most critical vessel first, let the patient recover, reassess their symptoms and hemodynamics, and then bring them back a month or two later to address another area. The optimum targets, the low-hanging fruit, are always the simpler blockages that are clearly feeding areas of viable or ischemic muscle. Those are the potential low-risk, high-reward interventions.
Okay, moving into the cath lab itself, what are the unique challenges these fragile hearts present during the procedure? Specifically thinking about managing that intra-procedural ischemia.
The number one physiological concern is avoiding any further ischemic stunning, and critically, minimizing any new periprocedural necrosis or heart muscle damage caused by the procedure itself. See, patients with normal heart function can often tolerate, longer balloon inflations, maybe some delay while deploying a complex stent. The ILVD patient often cannot. Any significant reduction in blood flow during the procedure can trigger a dangerous cascade. The ischemia causes stunning, which worsens the already poor baseline heart function. That can lead to low blood pressure, even cardiovascular collapse, and that whole process actually increases the burden of scar tissue, the very thing the procedure is often trying to indirectly address by improving function.
The review lists several clinical factors that should serve as immediate red flags, signaling a patient who's really teetering on the edge hemodynamically.
Yes, these are factors that demand extreme caution and probably a lower threshold for using support. They include the obvious things, like if the patient presented recently with decompensated heart failure, or if their baseline blood pressure is low, or if they have a low measured cardiac output to begin with. But the more subtle signs are just as critical. Things like significant pulmonary hypertension, meaning high pressures in the lungs, or if they've had a very recent heart attack, even if they seem stable now. Or, importantly, if there's evidence of right ventricular dysfunction. If the right side of the heart is also struggling, the patient's ability to maintain circulation during any procedural stress is profoundly limited.
Now, in terms of best practices during the PCI itself, the use of intracoronary imaging, IVUS or OCT, gets a strong Class I recommendation in certain situations. Why is seeing inside the artery so vital in this high-risk group?
Intracoronary imaging is key because it gives the operator much more information than the angiogram alone. It allows you to see the true nature of the blockage, how much calcium is there, what the plaque looks like, the actual vessel size. And critically, it confirms optimal stent placement, making sure the stent is fully expanded, pressed up against the vessel wall, covering the lesion properly. This is especially crucial in the complex situations often seen in ILVD, like treating blockages at branch points, bifurcations, or dealing with heavily calcified lesions. The review notes and multiple studies confirm that using imaging improves outcomes, both short and long term, particularly for these complex conditions.
But there's an inherent tension here during the procedure, isn't there? You're trying to achieve technical perfection using imaging, but you're balancing that against the patient's stability.
Absolutely. That's a constant balancing act in high-risk PCI. While we definitely strive for those quality metrics, like achieving the optimal minimum stent area based on the IVUS measurements, that pursuit of technical perfection has to be constantly weighed against the patient's real-time hemodynamic status. Sometimes spending an extra 5 or 10 minutes trying to post-dilate a stent to gain that last fraction of a millimeter might be the thing that pushes an already fragile patient over the edge into irreversible hemodynamic collapse. Pragmatism has to override perfectionism when you're dealing with severe LV dysfunction and the patient is becoming unstable.
Which leads directly to the critical role of continuous invasive hemodynamic monitoring. And this needs to go way beyond just watching the blood pressure, cuff, and heart rate monitor.
This is where right heart catheterization, or RHC, often using a pulmonary artery catheter, becomes an absolutely essential piece of the safety puzzle. And it probably still doesn't get used as often as it should in these cases. Systemic measures like blood pressure are actually pretty poor and late indicators of what's really happening with cardiac performance. RHC gives you real-time, in-depth physiological data that you just can't get otherwise. Specifically, things like the cardiac index, which is the patient's actual cardiac output adjusted for body size, and the left ventricular filling pressures, usually measured as the pulmonary capillary wedge pressure.
And how does having that specific RHC data translate into practical actions in the cath lab?
It functions as the team's early warning system. A rise in those LV filling pressures or a drop in the cardiac index often signals that the patient's hemodynamic are starting to deteriorate before their systemic blood pressure even begins to fall significantly. This gives the team precious minutes, potentially, to intervene proactively, maybe start vasopressor medications, or, crucially, decide to deploy mechanical circulatory support before the patient actually crashes. And furthermore, that RHC data provides the essential parameters needed not just to initiate support if needed, but also to guide how you safely wean that support off later, post-procedure.
Finally, the review makes a strong point that success in high-risk PCI isn't just about the operator's technical skill. It's deeply tied to the institution's capabilities and the whole system's rigor.
Yeah, this kind of high-risk work really demands specialized expertise and infrastructure. There's good data showing that high institutional volumes and high operator volumes for complex PCI correlate directly with better patient outcomes.
Hmm.
The whole system needs to be geared up to support this level of complexity safely.
What kind of non-technical preparation is considered mandatory before every single one of these high-risk cases?
The pre-procedure checklist is, or should be, exhaustive. It typically includes things like a formal pre-procedure evaluation by anesthesia, even if they aren't planning general anesthesia initially. Ensuring the defibrillator pads are placed on the patient before anything starts. Establishing reliable central venous access up front, not waiting until there's trouble. Notifying the hospital blood bank that a high-risk procedure is underway. Making sure all the potential mechanical circulatory support, MCS equipment, is in the room, prepped, and confirmed to be functional, and reserving a cardiac ICU bed for post-procedure care. And critically, there must be a mandatory team brief involving the operator, nurses, techs, maybe anesthesia before every single case. They need to explicitly review the patient's specific vulnerabilities, the anticipated procedural hazards, the planned technical strategy, and importantly, the agreed-upon emergency response protocols. Everyone needs to know exactly what their role is if things go wrong.
The paper also mentions this pilot and co-pilot strategy. That sounds like it's aimed at mitigating human factors like fatigue during long cases.
Yes, exactly. For particularly long or complex procedures, having multiple experienced operators available, potentially switching roles, may help mitigate mental fatigue and lapses in attention that can happen during multi-hour, high-stress cases. The overall goal has to be continuous quality improvement, and that requires ongoing effort. Things like mental and physical task training, maybe using simulation, and importantly, conducting mandatory post-procedure debriefs or after-action reviews, especially if there are any complications, to identify system flaws and figure out how to prevent them next time.
Okay, given those extreme procedural risks and the fact that these ILVD patients have so little cardiac reserve, mechanical circulatory support MCS often becomes necessary to basically get the patient safely through the PCI procedure. The review makes a key distinction between using MCS proactively, putting it in up front before the main part of the procedure, versus using it reactively, only as a bailout when things start to go wrong.
That distinction is crucial. The goals of using MCS are pretty clear. You want to protect that vulnerable left ventricle. Using it electively up front is primarily preventative. The idea is to shield the LV from ischemic stunning during potentially long balloon inflations or complex stenting. It helps maintain stable systemic blood pressure and ensures continued blood flow, perfusion to vital organs like the brain and kidneys, even while the operator is working on the coronary arteries.
And the data seems to suggest that waiting until you need it as a bailout carries a pretty significant penalty.
It does, unfortunately. Bailout use is purely rescue. It's deployed after the patient is already hemodynamically compromised, maybe even collapsing. While the data comparing elective versus bailout is mostly observational, so it's confounded by indication, it consistently shows significantly higher mortality rates when MCS is used in a bailout situation compared to when it's put in electively beforehand. Essentially, if you wait for the fire, the team is already behind the curve trying to put it out. So the decision about whether to use MCS ideally needs to be proactive. It involves carefully balancing the known risks of the MCS device itself, primarily vascular injury at the access site, and bleeding against the estimated risk of the procedure. How much heart muscle is at risk? How long do we expect the ischemic time to be? And what's the patient's underlying hemodynamic reserve?
Okay, let's quickly go through the main devices used for MCS in this setting and the evidence behind them, starting with the oldest and maybe least invasive one, the intra-aortic balloon pump, the IABP.
Right, the IABP. It's inserted typically via the femoral artery in the leg, and it works by counterpulsation. There's a balloon in the aorta that inflates during diastole, the heart's relaxation phase, which helps push more blood back into the coronary arteries. Then it deflates rapidly just before systole, the heart's contraction phase, which reduces the resistance the heart has to pump against after load. The key physiological effect is that it provides pretty effective augmentation of coronary blood flow, but it gives only a very small, often negligible increase in the actual cardiac output, the forward flow.
And the big trial looking at elective IABP use in this high-risk PCI population was BCIS-1, right?
Yes. BCIS-1 was a landmark UK trial. It randomized high-risk PCI patients defined by LVEF under 30% in extensive disease to either get an elective IABP put in beforehand or have no planned support with bailout available. The primary result, looking at major adverse events at 6 months, was neutral. Elective IABP failed to reduce the rate of death, heart attack, or stroke. Now, there was a later long-term follow-up analysis that hinted at potentially lower mortality way out at 5 years with elective IABP, but the mechanism wasn't clear, the finding was somewhat unexpected, and it's generally considered hypothesis-generating rather than definitive. So as a result, the IABP is rarely used electively for high-risk PCI anymore. Its main role now is typically as a bailout device, perhaps specifically to help relieve ongoing ischemia caused by a procedural complication, like an acute coronary artery dissection.
Okay, moving up in terms of support level, we have the percutaneous LV assist devices, or PLVADs. The most common example is the Impella CP. These actually pump blood, offering much more cardiac output support.
That's right. These devices are essentially miniature axial flow pumps. They're inserted, usually via the femoral artery again, and positioned across the aortic valve so they actively suck blood out of the left ventricle and pump it forward into the aorta. They can provide substantial augmentation of cardiac output, much more than an IABP, which can give the operator more time and stability to perform very complex, lengthy procedures. However, that powerful mechanical support comes with a significant trade-off. These devices require much larger holes in the artery for insertion the Impella CP needs, up to a 14 or 15.5 Frank sheath. And that dramatically increases the risk of serious vascular complications at the access site, things like vessel damage, limb ischemia requiring surgery, and major bleeding.
The pivotal randomized trial comparing elective Impella supports, specifically the older Impella 2.5, against IABP support, was PROTECT 2. What did that show?
PROTECT 2 was designed to show that Impella was superior to IABP. However, the trial was actually stopped early because an interim analysis showed it was futile. It was very unlikely to meet its primary endpoint. At 30 days, there was no significant difference in the composite primary endpoint between the Impella group and the IABP group. Perhaps even more concerning, a secondary analysis looking specifically at outcomes at 90 days suggested there might actually have been an increase in the risk of death, about 2.6% absolute increase in the group that received the Impella 2.5 compared to the IABP group, alongside higher rates of needing treatment for low blood pressure. So, based on that historical data from PROTECT 2, the evidence supporting the routine elective use of PLVDs like Impella for high-risk PCI remained pretty inconclusive, maybe even leaning negative, for quite some time.
And then finally, the highest level of support, but also the riskiest. Veno-arterial ECMO, or VA-ECMO.
Yeah, VA ECMO is generally reserved for the absolute most profound instability, like cardiogenic shock where the patient is crashing, or even during cardiac arrest. It provides the highest possible levels of blood flow and oxygenation because it essentially bypasses both the heart and the lungs entirely using an external circuit. However, it comes with a major physiological drawback, specifically for the failing left ventricle in this setting. The oxygenated blood from the ECMO circuit is infused retrograde, meaning backwards, into the arterial system, usually via the femoral artery.
And how does pumping blood backwards into the aorta hurt the already weak left ventricle?
It dramatically increases the workload, the afterload, on that vulnerable LV. Imagine the weak ventricle trying to eject blood out into the aorta, but the aorta is already being filled under high pressure from the ECMO pump flowing backwards. The LV struggles to eject against that overwhelming back pressure. This can lead to the LV becoming distended, overfilled, which can worsen pulmonary edema, fluid in the lungs, and also increases the risk of blood clots, thrombus, forming inside the poorly ejecting LV. So because of this significant LV afterload issue, VA ECMO is almost exclusively reserved for true bailout situations involving profound shock or cardiac arrest, often requiring additional strategies to help vent or unload the LV.
Now, the review puts a lot of emphasis on two very large ongoing randomized trials that are specifically designed to finally settle the controversy around elective PLVA use, particularly with the newer generation Impella devices. Let's talk about the differences between CHIP BCI-3 and PROTECT 4.
Yes, these two trials are absolutely critical. They represent the cutting edge of research in this area and should, hopefully, provide the high-quality evidence needed to rationalize how we use PLVADs. CHIP-BAY PBCIS-3, which we expect results from around 2026, is a somewhat smaller, highly focused trial primarily based in the UK. They're randomizing about 300 participants who have both severe LV dysfunction, LVEF or 35%, and very extensive coronary disease, high myocardial jeopardy. And they're specifically targeting patients undergoing procedures deemed extremely technically complex.
What defines that extreme technical complexity in CHIP BCIS-3?
They're looking at things like PCI, involving the left main coronary artery, procedures requiring extensive use of advanced techniques to modify heavy calcium, like rotational or orbital atherectomy, or intravascular lithotripsy, or attempts to open a chronic total occlusion, a CTO, a 100% blockage that's been there a long time, using the particularly challenging retrograde approach. Their primary outcome is also sophisticated. It's a hierarchical composite endpoint analyzed using a win ratio method, which is designed to be more sensitive in detecting potential benefits across a range of outcomes, including survival, freedom from major events, and potentially procedural success.
Okay, so CHIP BCIS3 is focused on extreme technical complexity. What about PROTECT 4? That one sounds much larger and more international.
PROTECT 4 is indeed much larger, aiming for over 1,250 participants, with results expected maybe a year later, around 2027. It's an international trial. They include patients with slightly less severe LV dysfunction, LVEF 40%, and randomize them to receive elective support with the Impella CP versus a control group, where elective IABP use is allowed but not mandated. Their definition of complexity is a bit different. It focuses more on the sheer extent of the coronary disease rather than just the extreme technical difficulty of treating one specific lesion.
So more about the total burden of disease rather than one super challenging blockage.
Essentially, yes. Their complexity criteria include things like having extensive 3-vessel disease requiring PCI of at least 2 vessels during the procedure, or needing to treat 2 or more complex lesions, where complexity is defined by characteristics like lesion length, severe calcification, needing to treat a bifurcation, a branch point, or treating multiple vessels. Their primary endpoint is a more traditional time-to-first event composite, looking at death, stroke, MI, or repeat revascularization, followed up for up to 3 years.
So the combined results from these two massive trials, CHIP BCIS3 and PROTECT 4, should finally give us the high-level evidence we need to figure out which patients undergoing which types of complex PCI actually benefit from the risks associated with putting in an elective PLVAD like Impella.
That's exactly the hope. They should help answer critical questions like, is a strategy of putting in MCS up front to enable a single-stage, more complete revascularization actually superior in the long run to a potentially safer but maybe less complete unsupported or staged approach? That single procedural strategy decision, go big with support upfront versus stage it without support, is currently one of the biggest areas of clinical uncertainty and disagreement among operators doing these high-risk cases. These trials should provide much-needed clarity. So despite this recent flood of trial data, particularly from Revive BCS2, the review is very clear that significant clinical controversy and, importantly, discordance between different society guidelines still persist. This is largely driven by the mixed nature of the big trial results and that ongoing lack of standardization we talked about earlier.
Right. That lack of a universally agreed-upon diagnostic definition for ILVD itself remains a huge barrier, doesn't it? It complicates comparing patients across trials and even applying trial results to individual patients in clinic.
It really does. And then trying to integrate the findings from SD, long-term TABG benefit, and Revive BCIS2, short-term PCI neutrality, remains the main source of friction in the guidelines. For example, the European Society of Cardiology guidelines currently give PCI a sort of lukewarm recommendation, a Class 2B, suggesting it may be considered particularly for patients who are at high risk for surgery but still have limiting angina symptoms. It's really trying to balance the procedural risk against patient preference and symptoms.
But the American guidelines, the AATCC, they take a more cautious approach, right? Based on Revive BCIS2, they don't make a specific recommendation for using PCI in stable ILVD patients purely for prognostic reasons.
Exactly. The AHCP position reflects the neutral outcome of Revive BCIS2 more directly. So this difference creates real confusion for clinicians at the bedside. You're forced to weigh this single, positive, but very long-term trial for CABG stitches against a high-quality, modern, but ultimately neutral trial for PCI over the short to medium-term Revive BCIS2. Probably the safest interpretation right now is that if a patient with ILVD is stable, maybe asymptomatic on really good GDMT, the added prognostic benefit of doing routine revascularization, especially PCI, is questionable outside of that strong S-stitch-based mandate for surgery in appropriate candidates. The focus really has to be on optimizing GDMT first.
The review also points out this massive and growing evidence gap in a related but distinct patient group, those with heart failure with preserved ejection fraction or HFpEF.
Yes, this is a huge population, probably represents half of all heart failure patients now, and they're notoriously difficult to treat. We know that about half of these HFpEF patients also have significant underlying coronary artery disease. Yet, Incredibly, we have essentially zero randomized trial evidence to tell us whether revascularization is safe or effective in this specific group. It's a major clinical blind spot.
But there's hope on the horizon. The trial pipeline is starting to address this gap with the REPRIEVE trial.
Yes, thankfully. Reprieved is an ongoing trial specifically designed to tackle this question. It will randomize HFpEF patients who also have CAD to either get PCI or undergo a placebo sham procedure. And importantly, its primary endpoint is focused heavily on changes in quality of life and functional capacity, using tools like the KCCQ score and exercise testing, not just on traditional hard MACE outcomes like death or MI. This really reflects a growing realization that for many HFpEF patients, where long-term prognosis might be driven by factors other than just the ischemia, the most realistic and important goal of an intervention like PCI might be to improve how they feel and function day to day.
Okay, looking back specifically at ILVD, the HFrEF population, what new trials are coming down the pike designed to maybe overcome the limitations of revived DCIS2, perhaps by mandating the use of more modern PCI techniques?
There are several interesting trials, quite a few originating from South Korea, actually. The Restore PCI trial sounds particularly ambitious. They plan to randomize around 900 ILVD patients to either optimal medical therapy alone versus PCI. But the key difference is that PCI in this trial comes with mandatory use of intracoronary imaging, IVUS or OCT, and coronary physiology testing, like FFR, IFR, to guide the procedure and ensure high-quality revascularization. They're explicitly trying to optimize the PCI technique itself. They'll be tracking MACI outcomes and also changes in LVEF, with results probably not expected until around 2030. There's also the Improve ICMP trial, smaller but similarly focused, which is primarily looking at the difference in LVEF change at 6 months between optimized PCI and medical therapy.
And what about that nagging question regarding CAB? Does the survival benefit seen way back in STICKAs still hold true in the era of modern, potent GDMT? Is anyone retesting that?
Yes, that's being directly addressed by the MENA SS4HF trial currently underway in Brazil. This trial is randomizing about 600 patients who have LV dysfunction, CAD, and documented ischemia to either conservative management, which presumably includes modern GDMT, versus CABG surgery. This should give us a much clearer picture of whether that long-term survival advantage for surgery persists when the control group is receiving today's best four-pillar medical therapy, something the original SDH control group obviously didn't get.
And finally, the great unanswered question, the elephant in the room, the direct head-to-head comparison. How does modern PCI actually stack up against modern CAG, specifically for improving prognosis in ILVD? Will we ever get a definitive answer to that?
The authors point towards what sounds like a monumental effort, the SDI-CH3 consortium. This isn't just one trial, it's a huge international collaboration planning to pool data from 9 different randomized trials, aiming for an aggregate sample size of over 2,500 patients. And its explicit goal is to address the hypothesis head-on. Is CABG superior to PCI in ILVD patients who already have a clear clinical indication for revascularization, like an acute coronary syndrome or severe limiting angina? Given the massive scale of this consortium and the need for long-term follow-up to potentially see differences emerge, the results aren't expected until sometime after 2030.
Wow. So that means for the better part of the next decade, clinical practice really will be guided by the kind of nuanced, evidence-based synthesis presented in this review paper.
Absolutely. Which brings us to the final, really provocative thought the authors leave the reader with. They argued that the current evidence supporting routine revascularization purely for prognostic reasons in stable ILVD patients is, frankly, weak. Neutral for PCI, delayed, and maybe GDMT dependent for CABG. And the fundamental underlying problem might be that we don't actually know with certainty if the procedures we perform, whether it's CABG or PCI, truly succeed in functionally removing the ischemic substrate, the burden of ischemia, over and above the powerful effects of modern GDMT.
Meaning we're good at measuring the downstream clinical endpoints like deaths or hospitalization, but maybe we haven't been rigorously measuring the direct physiological effect, the reduction in ischemia achieved by the procedure itself.
Precisely. Their argument is that future studies really need to pivot. We need to move beyond just reporting ARE outcomes and start focusing on objectively quantifying the change in ischemic burden after the procedure compared to before. Only by truly clarifying the actual physiological impact of our interventions can we rationally define the relative value and the appropriate patient selection for PCI versus CABG in this incredibly complex and high-risk patient population.
#tag outro.
Well, this has been an incredibly informative and I think really crucial exploration of a very complex and high-stakes area in cardiology. We've unpacked the intricate pathology of ILVD, stunning hibernation scar. We've wrestled with reconciling those conflicting long-term trial results, the delayed benefit of TABG from stitches versus the neutral short-term PCI data from REVIVE and BCSO2. And we highlighted that major shift away from using viability testing as a tool for prognostic selection. And importantly, we really dug into the details of the extreme procedural planning and systems-level rigor that are absolutely necessary for performing high-risk PCI safely in this fragile population. We emphasize those non-technical factors, the vital role of invasive monitoring like right heart cath, and specific procedural best practices. We also looked ahead at the potentially practice-changing evidence we expect soon from those major mechanical circulatory support trials, CHIP BCIS-3 and PROTECT-4, which should hopefully bring much-needed rationale to how we use devices like Impella.
It's clear the journey towards truly personalized, evidence-based care in ILVD is definitely ongoing. But the kind of rigorous pathophysiology-guided approach that's laid out in the state-of-the-art review provides a clear, actionable framework for clinicians navigating these complex decisions today, always centering the individual patient's risk profile, their symptoms, and their preferences.
Absolutely. That synthesis of aggressive, optimized, guideline-directed medical therapy combined with highly selective, meticulously planned revascularization when indicated, all guided by a well-functioning communicative heart team that really represents the current gold standard of care.
Thank you for watching The Fungal Effect.